Zoom recording. Okay, now the recording is on.
Okay, great.
Okay.
Well, thank you for inviting me. I mean, I completely agree. This kind of thing is really fun just in normal times, but especially during this weird time where we're all isolated and have, limited opportunity to interact. And it's out of that, I think, is born this opportunity to share and find creative ways to share and to get more information out there and more learning opportunities. So I'm excited, and I think it's a great idea. I don't think it's a crazy idea. My husband and I were actually talking about how it's something we've thought would be really neat to be able to not only do more webinars, like for me to do more webinars, but also to reach out to people in other countries, because that's one of the great things is that you can be on the other side of the world and we can still have this common interest. So it's neat. So thank you for inviting me. I'm excited. Yeah, so my name's Kate Baker. I'm not sure how many of you that are watching are in the Cytology Coffee House group, but that's a Facebook group that I started. I guess it's been about 2 years now. Yeah, just about. And I started that group with not really knowing exactly like what would happen with it and how big it would grow and how awesome it would be, but it's been such a great place for everybody to share cool cases and learn from each other. So that's been a ton of fun for me over the past couple of years. I work for Antech Diagnostics as a clinical pathologist, so that's my day job, and I love it. I get cases every day, and right now I'm working from home, so it's which sounds luxurious, but when you've got a 2-year-old, it's a little bit difficult. And we're also expecting our second baby in August, so we're very excited. We've got a lot going on, but it's all very good stuff. So this for this talk, we had decided to choose a couple cases where the presentation wasn't necessarily leading us to what the final answer ended up being. So for my case, it's hard to choose because we've got so many options, so many different clinical cases where you're like, wow, the answer ended up being a surprise and it was revealed in the cytology. But the case that I chose hopefully will be very interesting for you guys. It's one of those that is very interesting for me, even though I see this pretty frequently. I know it's not, this is not necessarily common in every area. I won't give the answer away, but I think it's a good case to demonstrate, how important cytology is and not to assume the answer just based on presentation. So with no further ado, I'll get started on my case. So for this case, this was a 4-month-old male intact boxer puppy. And this dog had presented to our emergency room. He actually presented, my husband was working that day. My husband is an emergency veterinarian at the same practice that I work in. And this was when we were both at work, when I was at work also. So I got to see this dog as well. And I'm going to try to talk a little slower because we had talked about how sometimes it's a little difficult to understand my accent. So I'll try not to get overexcited and talk too fast. But so this dog had presented to our emergency service, just not doing well. His clinical signs were fairly vague. He wasn't gaining weight like a normal puppy should. He wasn't eating well, so that correlated with that lack of weight gain. And he was profoundly weak and lethargic when he presented. So he definitely was not normal at all for a puppy. And it was a little hard to pin down exactly when this started, but it seemed that it had really become most evident in the past few weeks prior to presentation. But he had been off for quite a while, several weeks at least. So on his clinical exam, this is actually him. This is a picture of him. A really cute little puppy, very sad looking. This is obviously not normal for a puppy to be just flat out on the table like that. And he it was very evident on the clinical exam that he had extreme lethargy and weakness. So he just was not himself at all, or what a normal puppy should be. And then they took his temperature and he was febrile. So I don't know what that is in Celsius, but That's a very high fever in Fahrenheit, 104.5. And he also had diffuse muscle wasting. Again, dull mentality, just not interacting normally. He had a grade 2 out of 6 left-sided heart murmur. And then he did have peripheral lymph node enlargement. So his popliteal, I'm sorry, I put popliteal in there twice, but both popliteals, bilateral popliteals, and right-sided prescapular lymph nodes were large. And then on physical exam, my husband did notice that he had, excuse me, hepatosplenomegaly. So his spleen and his liver were enlarged. So something clearly is not right with this dog. The question at that point was what? He kind of got bounced around a little bit from our services because we have several different specialty services at our hospital. And it wasn't really clear exactly where he needed to go. He was clearly critical, but his murmur raised the question of if he needed to go to cardiology. Because of his lymphadenopathy, was unsure if he needed to go to medicine to get that checked out. So there were some discussions there, and ultimately some initial diagnostics were done in the emergency room to sort of get more information about what was going on with him, to be able to figure out where he needed to go for, what was going on with him and where he needed to go from there. So, sorry, I'm following along on my screen here on the side. So the first thing that they did was they did a CBC. And here you can see a lot of blue and a lot of red. So things were off here on the CBC. And the main things here are that he had a bicytopenia. So he had a severe anemia at 14.2%. And he had a thrombocytopenia. His platelets were counting at 20,000, which was confirmed on the blood smear. So he had that anemia and thrombocytopenia, that bicytopenia there. His neutrophils were in the normal range. He had a mild monocytosis, which could have just been stress, so not really that exciting. His anemia was microcytic. So when we see that microcytic anemia, that makes us, at least it makes me wonder about iron deficiency anemia, because that's a potential cause of that. He is a puppy, so some of that microcytosis could be from his age, because the puppies can have microcytic anemias, but this degree of anemia is certainly not normal for a physiologic, anemia in a puppy. So bicytopenia, there's a number of things that can cause that, but at that point when you have multiple cell lines in the CBC that are low, one thing to think about is there something going on at the level of the bone marrow? And so that's where we were kind of thinking what might be going on there. So things still weren't clear at this point as to what was happening in this dog. But this CBC at least gave us some information, but not an answer. But we did find an answer later that explained this. So that's what we'll get to. So the next step was to do an AFAST ultrasound, which stands for abdominal something. FAST is an acronym for, my husband always tells me what it means, but I always forget. I'm sure you guys, some of you at least in the group, know what that stands for. But it's an ultrasound that they perform in the ER setting that gives them some general information. It's not your complete ultrasound by your radiologist, your internal medicine specialist, but it's a ultrasound specialized for the ER. So on this dog's ultrasound in the emergency room, one of the main findings was this dog had marked abdominal lymphadenopathy. So his abdominal lymph nodes were huge. And here's an arrow drawn to one of them. And I'm certainly not a radiologist. I know you aren't either. It's been a while since I've interpreted radiographs, or imaging of any sort, really, but ultrasounds included. And but even despite that, I can tell this is not normal. And this is just a very huge abdominal lymph node. And here's the spleen up here. So this was clearly not normal. Didn't give us an answer as to what's going on in the dog, but certainly added some layers of complexity and question about what might be considered on the differential list. And then thoracic radiographs were performed. And here you can see, it's not, well, so they tell me. Again, I don't interpret thoracic radiographs anymore, but you can see that there's a mild diffuse bronchointerstitial pattern. So the lungs were not normal. They weren't, marked changes, but that was what the radiologist reported, mild diffuse bronchointerstitial pattern. So at this point, we got together, and I was helping them on this case and said, what could be some potential differentials for this dog? Putting it all together, one of the main concerns was that this puppy could have lymphoma. And now I know it's a young dog, and that's very unusual, but I have diagnosed puppies with lymphoma before. The youngest one I had was 3 months old. So certainly can happen. And this is, any like this degree of illness and changes in a young dog is unusual anyway. So, we were still thinking about differentials that could explain these things. So lymphoma was the primary concern, the enlarged lymph nodes, even the pulmonary changes on radiographs, the biocytopenia. We thought, well, maybe, there's neoplastic cells in the bone marrow causing issue there. Fever is a little bit unusual. Well, I shouldn't say it's unusual. You can definitely have fever associated with lymphoma, but that's not the only thing that can cause that, as we'll find out. So all of these things together just really made us concerned about cancer, specifically lymphoma. And so how are we going to find an answer? We're not going to just assume. The next step was to do an FNA, which is where I obviously came into this whole process. So this is my husband aspirating this dog's spleen. He actually went for the spleen instead of the abdominal, he did both, the spleen and abdominal lymph node. And I took a look at both. I had pictures of the spleen though, because that was it was the best sample. So here he is aspirating this dog's spleen with ultrasound guidance and getting samples that way. And this is what I saw when I put the slides up on the microscope. So I want you guys to take a look at this picture, everybody watching. And as I'm kind of starting to talk, see if you can find the abnormalities, because they're right there in front of us. This is a case where, the answer is right there, which is why I love cytology for so many reasons. But, there's no more need to investigate further. We have the answer just clear as day right in front of us. So a normal splenic aspirate should have lymphoid tissue. It's usually pretty bloody because the spleen is very vascular, but the spleen is a lymphoid organ and should have a mixed lymphoid population predominated by small lymphocytes. And then it can also have other components to it. We've got like splenic stromal aggregates, which are spindly type cells that live in the spleen, and then some other things. But here we can make out, I think you probably should be able to see my cursor. Might be kind of small. I'm looking at my phone to see, but here we can see in the middle, and then down here, there are a couple lymphocytes, and they're fairly small in size. There's a neutrophil here. Here's another lymphocyte. So it's not a supracellular area of this slide, but it was an important area, because here you can see these cells, and these are macrophages. So they're kind of falling apart. Their borders are sort of getting a little bit kind of like whisked out to the side because they're falling apart. But here inside these macrophages is the answer to our case. And looks like we've got some answers here. Awesome. Gustavo is looks like the first one to say it. So that is histoplasma. So histoplasma, these are all little fungal yeasts inside of these macrophages. And they've got these characteristic features for histoplasma in particular, where they are small, and size is really important when you're looking at fungal organisms. because they really can vary in size. The different types can vary in size. Excuse me. And in this case, these are very small. So you can fit a good number of these inside of a macrophage. And this one's clearly doing its best to clear up, what it can, but it's fighting a losing battle, unfortunately. But the morphology of these is beautiful and classic. So histoplasma are small and round, and they typically have this kind of crescent shaped internal structure to them and a very thin, clear capsule. So this is usually diagnostic for histoplasma. Now, my caveat is there are cases where other types of fungal infections can look very histoplasma-like. Things like sporothrix, even some other types of kind of more obscure fungal infections can look kind of histoplasma-like. But here, at least where I live, this is histoplasma. I wouldn't expect sporothrix to present in internal organs. I'm interested to know do you guys see sporothrix in Italy?
Sorry, I didn't hear the question. So the question is if we have such infection, or if you want
with sporothrix in particular. Do you guys have sporothrix there?
Not to my knowledge. So
okay.
I just see one, but not in Italy. It's come from Malaysia, so absolutely it's not a resident.
Okay. Yeah, we have it here in the States. I've only seen one case of it before, and I look at just like you, I look at a ton of cytology. So just based on my anecdotal experience, sporothrix is not very common, at least where I live. But that's one that can look very similar to histoplasma, but usually sporothrix is going to present as a, facial lesion, more common in cats.
Skin.
Yeah. So I do think, actually this got brought up on the Cytology Coffeehouse page some months ago, where somebody was talking about how it could present systemically, but I don't know that for sure. I'd have to look more into that. But in any case, here where I live, this is diagnostic for histoplasma. The morphology is classic. It's common enough here that we feel comfortable. The presentation of this whole case was very classic for histoplasma. So one thing I mentioned was, we had originally been thinking, well, maybe this is lymphoma. But again, here, because fungal infections are so common, so things like histoplasma, certainly blastomycosis, coccidiomycosis is not common in my state. It is more common in Arizona and Colorado. But so those morphologies don't fit with this at all. But I'm just mentioning clinically, when an animal presents with kind of nonspecific signs and fever and lymphadenopathy, we also consider fungal infection on our differential list pretty much always here because it's so common. So we did have fungal infection on our differential list, but we were still thinking it was probably lymphoma, but it certainly was not. And we have the answer to that right here in front of us. So one of the really neat things about cytology is that there it is, the answer. That dog came in, and within an hour, we had an answer to why this dog was so sick. So because of the CBC abnormalities, we had an answer for this dog, but I said, let's look at a blood smear because I'm presuming that this infection is in this dog's bone marrow because we did have those cytopenias. And one way, to kind of assess that as a possibility, or at least to support that, would be if we found organisms in the blood. And it is not common to find these fungal yeasts in the blood, but you can find them. I've only seen a few cases of histoplasma in blood. They're very exciting days for me because they're so uncommon. It is very cool to see them. And again, when I say things are cool, I totally do not feel like it's cool for the animal. I don't mean to be insensitive, but in pathology world, things that are cool are usually not good for the patient. But in any case, I was thinking, let's go back and look at the blood smear and see if we can find any on the blood smear. Well, there they were. So it took a little while to find these. And they were actually inside these cells in the peripheral, in the feathered edge of the smear, because they were kind of heavy, bogging down these cells. And this cell is sort of busted apart, but you can see them. They were inside of the cytoplasm of this cell, and they look exactly the same. So these little small circular yeasts all here huddled up inside of this cell. So this dog was completely riddled with this fungal infection. It was in its spleen, it was in its abdominal lymph nodes, it was in it, presumably in its peripheral lymph nodes, because those were enlarged. We didn't aspirate those, but the presumption is it was there. And presumed in its bone marrow. We didn't do a bone marrow exam, but putting all the pieces together, it was this would support that with the bicytopenia. So just wanted to do a quick little note about histoplasma, because I know it's not common. I know you had mentioned it's not seen in Italy, and it's not going to be seen in a number of different countries. So I still hope it's interesting to you guys, even though you don't see it. You may have a patient with travel history, come in that you need to be able to recognize it. We don't have leishmania here, but we occasionally see it in dogs that have travel history. So it's important to keep in mind in any country, really. But histoplasma, it's a dimorphic soil-dwelling fungus. So it lives in the environment in a certain form. And then when it is inhaled by the patient, it changes form into these little yeasts once it gets into body temperature. And those are the yeasts that we're seeing on the cytology. And it is not infective between animals or between animals and people, because you have to inhale it from the environment. And something we had talked a little bit about was that there is a presumption that animals that are immune suppressed are more susceptible to developing these fungal infections. So certainly that's true, but there are animals that are seemingly healthy and completely normal, not on any immunosuppressive drugs, nothing like that, and they develop these infections. So I think the jury's still out a little bit about why exactly some animals develop this and others don't. It's not very common in super, super young animals like this dog, but again, here it is, it happens. So I don't know if this dog was immunosuppressed, genetically, or, had something like that going on that made him more susceptible to this infection. But like I mentioned, it is very common where I live in the southern United States and also in the Midwest. So it's really along the river valleys, in those general areas that we see this most commonly. But there are other areas of the United States and Canada that have histoplasma, and that animals develop that infection. And it's quite common in cats as well. So dogs and cats can get it. It can, I think I had another little spot here that had some information there, but what happens is they inhale this organism, and then it disseminates throughout the body. So it goes, to the lungs first, and then it just spreads. GI, the gastrointestinal system, is a really common place for it to set up shop, but you can find it anywhere: skin, nasal cavity, bone marrow, anywhere. I mean, it can go anywhere. So unfortunately, this little puppy, this is just a little follow-up for the clinical people interested in the clinical aspect of this. He was admitted to our ICU. He was given blood transfusion and plasma transfusion and started on antifungal therapies, which I believe itraconazole is the therapy of choice. But I don't do treatment, so don't quote me on that. I'm not a clinician. But antifungal therapy is kind of your best shot with these intense supportive care. And animals can recover from this, but it can be very difficult to treat, especially when it's this systemic and this bad. So this pup, they did want to attempt treatment, and he got lots and lots of snuggles during his time in the hospital, including by me. I spent a lot of time with him. But he got so ill through the night. He was going to die anyway. So there really was just no hope for him, unfortunately. So he was euthanized, but you know, it was comforting, I think, to the owners to at least have an answer, to understand what happened, and you know, nothing they could have done to prevent it. So it was a really good case for everybody to learn from, and to realize how quickly cytology can get you an answer. So that was really the neat part of this from the pathology perspective. And that, you know, the presentation kind of seemed very neoplastic, even in a young puppy, but ended up being infectious. So I love infectious disease because if you find it, a lot of times you can say what's wrong. You know, you can identify it. Sometimes it's a little bit tricky, but this was one that was very straightforward.
Yeah, very sad story.
Yeah, it was. He was obviously a really sweet puppy, but you know, it was one of those that I gathered all the doctors that wanted to look at the cytology, all the interns in the hospital, and show them all the cool cytology part of it, because it really is a good example of this infection, and it happens here, so it has to be on everybody's radar for sure. So,
and unfortunately, you know, it's not rare, no, that cases that are so interesting for us, for cytologists, so amazing, where that had a sad end, huh? Not a good end. And
yeah, it's hard because you want to be like, wow, this is awesome, but you understand, yeah, but you understand that it's somebody's pet, and you know, since I'm inside of a hospital, I actually do see these animals, some of these animals, like with my own eyes. You know, it's a little easier to disconnect when you're just getting your cases, and
simply getting slides from other clinics without any involvement with the owners, you know, with the it's absolutely better.
Mm-hmm. Yeah, but you know, it's a good thing to be able to have that teamwork with the veterinarian. And you know, I would obviously never call them and say like, wow, how cool, you know, because I know that they're the ones that are having to tell the owners. But yeah, working with my husband and working in this hospital keeps me, I am a pathologist in part, obviously I love it, but I don't want to have to deliver bad news. So.
Yeah, for sure, you have the final word. And there is a question for you, Kate.
Oh, sure. Mm-hmm.
So Stephen asked, what stain did you use for finding the last period for this case? Do you use diff quick help or need special stain? Thanks.
Great question. The stain I used in this case was Wright-Giemsa, which is the standard laboratory stain for diagnostic labs. But it's very, very similar to diff quick. So these organisms would look essentially the same on diff quick. And there's no need to use a special stain to make them show up.
Okay, thanks. This
point. And Francisco, I just saw here mentioned that Blastomyces parvis and Candida galbrata can look very similar, and I totally agree. Those are a couple of great examples of ones that can mimic histoplasma. So again, there are some types of fungal infections that can look very similar. So one thing you can do just to confirm what you're seeing cytologically, especially if there's any doubt, you know, if the organisms don't look quite right, or if the clinical presentation isn't quite right. Here we have a test. It's actually called the Blastomyces urine antigen test. But it cross-reacts with histoplasma, and so you can confirm that way. But then I wonder if that would, since it's a blasto test, if that specific one that he mentioned, Blastomyces parvis, I wonder if that would still complicate it. I mean, you could do. I'll just put this out for the pathologists and you as well. Like you don't deal with this infection, so you may not know, but anybody that's watching that is familiar with other additional diagnostic testing you can do to confirm that species or that it is histoplasma, aside from, I guess you could do or IHC if you did biopsy, but that's kind of that's invasive. So I'd be interested to hear if anybody has any ideas for other confirmatory tests for histoplasma, but that would be the one that is at least used in our hospital a lot, the Blastomyces urine antigen test because it cross-reacts with histoplasma. Yeah.
Okay, very interesting cases in such
Yeah.
young animal.
Yeah.
It's not common. And unfortunately, the immune system of this poor puppy was not ready to fight
Right.
this fungal infection. And as I told you yesterday, you know, in the old Europe, we are a little bit envious that you have so many fungal infection that we don't see.
Yeah, it's good,
But,
good and bad.
and especially now, the traveling is blocked. So
All
we
right.
hope the tourists start to come back to Italy
Yeah.
again.
Bring your fungal infections to
Yeah,
Italy.
some fungal infection. But it's the same happened with Leishmania, no? When we
Yeah.
have an increasing tourism from the southern part of Europe to the northern part of Europe, and so they spread also some infectious disease like Leishmania that are
Yeah.
not well recognized, easy recognized in from people that are not used to face
Mm-hmm.
the disease.
Mm-hmm. Yep, exactly.
Okay,
Well, that's all I've got for mine. So unless there's any more questions, we can see what you've got for yours.
yeah, I'm checking if you have some other question. No, I have no question in the chat. So maybe we can exchange the role. So
Oh yes. Yeah.
give a
Stop
look
share.
to the chat and to the
Yep.
Facebook page. And okay, let's start to share the screen. Hopefully it works. Okay. Okay, do you see my screen now?
There's a little bit of lag, so just hang on one second. I see you. I think it's coming. Yeah, there's just a little lag, so it's coming up.
Okay,
Yep,
probably.
there it is.
Okay.
Yep, we're good.
Okay, so this is another case that we think that is quite interesting because once again, we have a clinical presentation, but cytology tell us the true story of this cat. This story is the story of Bibo. Bibo is the name of a very beautiful black cat, 10 years old, mainly indoor and goes sometimes outside in a small garden. And the owner report that this cat started to drooling some days and experience also some episode of dysphagia and some noisy breathing. So the owner heard some rumors during the respiratory. So he brought the cat to the visit, and after sedation, we discovered this kind of lesion at the base of the tongue. Oh my gosh, this is not a good sign in a cat, especially because if you look at this kind of lesion, this is localized in a specific part of the tongue, the base of the tongue. And we know from a clinical point of view that this location is quite typical for some tumors. So the primary concern of this lesion is that to be a neoplastic lesion, but it's a cat, and we know that we have a lot of differential in this case. So the classical approach in this case is to take a sample from this lesion. And so some sample were taken, and at the same time, during waiting for the result, the cat had a tomography. And I will show you, I'm not a radiologist, but I can show you some picture that was described from our radiologist. So this is some section of the examination. And this is a section more or less at the base of the tongue in which we can appreciate a large mass here that invade the nasal, the respiratory tract here. And as you can see here, this white part are part of the larynx, the hyoidal apparatus. So don't ask me the name of all these teeny bones that make this apparatus because I can remember. And the radiologist notes also that this mass infiltrate and disrupt in some ways these bones going outside. This is another picture in which we can better appreciate the involvement, also the external part and the lymph node here. And once again, this is the involvement of the lymph node in this part, supposed to be a lymph node. So the radiologist expressed the concern that this could be more or less 100% tumor that probably start from the tonsilary part, invade the larynx and the lymph node. And the list of diagnostic, differential diagnostic is a squamous cell carcinoma or a lymphoma. Of course, as every good radiologist, he put in the list also the possibility that this could start is a strong presentation of inflammation or infection, but he considered this less probable respect to the possibility to have a tumor. And even we don't hire radiologists here, but we can appreciate that this mass is highly suggestive to be neoplastic. So let's go to see what's happened when we try to take a sample from this lesion. So as you know, we can use different technique to collect sample from this lesion, no? And the first one that apparently is the most easy is to simply put a slides over the lesion, so it's called the direct impression. The second step could be a needle core, that means sticking a needle inside the lesion in several directions without aspiration. And the third one is the fine needle aspiration, that is reserved mainly for the cases in which the needle core is not able to recover enough diagnostic cell. And in this case, the impression of the slides that personally I don't like, collect a lot of inflammatory cells and some necrotic tissue. And this is exactly what is expected to find in an inflamed lesion in the oral cavity, because ulcerated lesion in the oral cavity usually are infected because in the mouth there are a lot of bacteria. So it's normal to find neutrophils and bacteria of different strain of bacteria. But it's very rarely this kind of technique is diagnostic in my experience, except for a few exceptions, of course. Then the needle core, in this case, probably because this technique must be absolutely accurate. If a lesion is superficial, that means that involves mainly the first layer, and if you go with the needle and too much in depth, it's possible that you miss a diagnostic sample. And consider also the tongue is a muscle, and taking sample from a muscle is not always easy, and there is always a lot of blood inside. And in this case, the needle core reveals just a lot of blood, and once again, some inflammatory cells, some neutrophils, and some eosinophils, and some other necrotic material. And finally, the fine needle aspirate. And now we can see this fine needle aspirate and try to understand what's happened in this lesion. I'm curious and to know at this moment of the clinical presentation, what are your ideas about the possibility? What is your list of differential? Because if I have to bet 2 cents of the diagnosis at this point of the clinical presentation, I would bet for sure my money on a neoplastic lesion. Okay, let's start from a low magnification. So in this case, we have quite many picture, just to try to give you the same idea that we have when we look at slides under the microscope, because in my opinion, cytological diagnoses are difficult on picture. The true diagnosis need to have a slides, because you must be free to go all around the slides and to understand what's happening. Just a single frame, a single picture rarely is representative of the whole situation that we have in the sample. So in this case, we can appreciate a low magnification, a lot of inflammatory cells, and this beautiful pink strand of material that comes from the disruption of the cell, of the breaking of the cell that release the nuclear material in the background. And we can immediately appreciate that we have another population that at the first sight look fuse, especially in this case. And for sure here we have an epithelial cells, and this is clear if you look at the size of the cell and the presentation of the cytoplasm that are usually this frozen glacier aspect that is typical for keratin. This is normal because we are in the mouth. It's normal to find some epithelial cell. So let's to give a look at the increased magnification in a few pictures. So once again, another population of apparently mesenchymal cells that that deserve to have a look a little bit more in detail. Okay, so here we have a beautiful detail of this population that for sure are mesenchymal with this long tail, with this wispy cytoplasm, basophilic with these small vacuoles that are mixed with an inflammatory population of basically neutrophil and some eosinophils, like in this case, even if this nucleus is not polymorphous, because simply this is an old eosinophils in which the nucleus lose the segmentation. So be careful, and because the evaluation of mesenchymal cell in cats is always meaningful. We know that cats has the amazing ability to react in any situation, both inflammatory or neoplastic situation, with a reaction of fibroblast or other mesenchymal cells that take a presentation very, very ugly. They can easily mimic a neoplastic condition, even if they are just reactive. In this case, we can, for example, in my opinion, give a look to nucleolus. Nucleolus is a good spy, is a good indicator about the true nature of the cells, because generally neoplastic cells shows some difference in nucleoli. When you see nucleoli that more or less are of the same size, the same shape, probably, of course it's probably, not 100%, it's probably they are just reactive. And you have to put in account that in many situations also, for example, in some tumor like a mast cell tumor, sometimes the reactive fibroblast looks so ugly that can mimic a primary mesenchymal tumor with an inflammatory component. But in truth, the plastic component are the mast cell and the fibroblasts are just reactive. Okay. Another picture, another detail of these beautiful mesenchymal cells that looks very nice and sometimes can take your eye, and so you might not be distracted by this cell. And looking here, for example, you can see some inflammatory cells that when we don't see granules, it could be difficult to understand if some cells are neutrophils or degranulated eosinophils. In this case, this cell looks like neutrophils, and then we can appreciate some eosinophils here. Some quite abundant granules are visible in the background. And remember, do not forget to examine the background. That sometimes give us interesting clues that can help us to guess what kind of situation we are looking at. This cell here is a mast cell. Mast cell in cats are not weird, because you know that cats have a lot of mast cells, even in normal condition, for sure in inflammation. And so it's not strange to find a mast cell in an inflammatory context like this. Another eosinophils here. This is probably a plasma cell. So this is a lymphocyte, medium-sized lymphocyte. So for sure we have an inflammatory context here. Another lymphocytes here. And remember, if you want to consider and to understand the size of the cells, to compare this with the neutrophils, or better with the red cells, that is our measurement units. So more or less, a red cell is about 7 micron. So we can have an idea quite precise about the size of these lymphocytes. Once again, another picture, and in this case, we can appreciate a criteria that can be suspected, but once again, don't be impressed by the anisokaryosis that we see in this case. Okay, take in account, but consider always the presence of nucleoli. the shape of these cells and the number of these cells could be worrying in some ways, but remember to consider the overall presentation. And here, even here, we have a lot of inflammatory cells. Eosinophils here, 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 mast cell, and probably mast cell here and here. Another picture in which we can appreciate the kind of inflammation that we have, even if in this part it seems that the inflammatory cells are less than half and half between eosinophils and neutrophils. So at the first sights look like an inflammatory condition. But if you go a little bit around, and especially in some on the edge of the slides and at the end of the slide, because remember that when you make a smear, sometimes happen that the largest cell, the heaviest cell, goes to the border because they simply weight more than the other cell. In this case, we can appreciate a cluster of a quite large cell that are for sure epithelial, and we can easily say that these are epithelial because if you look at the size and at the definition of the borders of the cytoplasm of the cell, that are easily identified as epithelial. And the look of the cytoplasm for sure indicate that we have an accumulation of keratin. This frosty appearance, this glassy appearance here is compatible with the keratin accumulation. If you consider this cell, the presentation is quite monomorphous, so I'm not so worried about this cluster. And this is normal to find a cluster like this, especially when we are in a context of inflammation. So dysplasia is expected to be found in this content. And if you look at these neutrophils here, these neutrophils are not overimposed to the other cells. So this is not a problem of the smear, but this is a true migration of these neutrophils through the cytoplasm of epithelial cells. And this is a name. It's a quite strange name. It is called emperipolesis. Emperipolesis is a migration of inflammatory cells that from the deep layer of the mucosal tissue goes through the epithelial cells and up to the surface where they can fight the infection or the presence of bacteria. When we see epithelial cells, our main concern as cytologists is to understand if the cells are simply dysplastic, or they can show some feature that can be suggestive of something different. If you look at this cluster here, and you look at especially the chromatin pattern and the shape and the number of nucleoli, in my opinion here, we don't have any signs to be worried because these cells are quite monomorphous. The chromatin is fine, and we have no specific sign of malignancy. But look what's happened if we continue our exploration of this sample. Here, in this case, we can appreciate that some things could be a little bit different, especially in terms of nucleoli and in terms also of maturation. Because when we consider epithelial squamous cells, one of the criteria that is most important to be evaluated is the phenomenon that is called the asynchronous maturation. So it's a problem in which we have a maturation of the cytoplasm that looks like a mature cell with a lot of keratin inside, and a nucleus that appear still young, still mature, still active. So what's happening in normal maturation of non-epithelial cells? That during the accumulation of keratin, because keratin generally is quite toxic for the nucleus, because keratin prevents the oxygen exchange, for example, and even the transportation of material that the nucleus needs to survive. The nucleus in normal epithelial cell during the normal maturation process tend to become smaller and smaller, tend to shrink and become pycnotic. So every time that when we see a mature aspect of the cytoplasm and the nucleus that are still large, still active, we are a little bit worried. So the problem for us at this point is to understand if this is a simple dysplasia. So these are really not mature cells, are quite young cells, but simply they react with accumulation of keratin to the fact to be in an inflammatory context. So they try to protect themselves against the inflammation, or this change are something more. This is another picture of the same cell on a border of a cluster. But look sometimes what's happened when we discover in a corner a cluster like this. I can give you some seconds to see, but if you compare this cell with the previous one, in which we have a large cytoplasm, an abundant cytoplasm, in this case, we can appreciate a marked reduction of the cytoplasm, so that in cytological terms is indicated like an increased nuclear cytoplasmic ratio. That means that the nucleus is more bigger than expected. So this means that this group of cells are immature cells. And the presence of this cell here indicates that the nature of this cell is still the same, epithelial cell. At this point, in my opinion, I become to start worried. Because in truth, especially the presence of young cells like this, and remember that in my mind, there is still the radiological presentation, and sometimes it would be better not to know such details that can influence us. Because if you don't know what's happened, sometimes we are more free. On the other hand, if you don't have clinical details, we complain with the clinician because we have not enough clinical information. So we are never happy in either situation. So in this case, and more in this situation, I'm really worried about the nature of this. And in my opinion, here we have some indication, especially because once again, I'm still thinking to the radiological presentation, and I'm really worried that this cell could be really neoplastic. Once again, this is another part in which we appreciate also a marked anisokaryosis here, and especially the nucleolus here is quite prominent. And we have cells that are really suspect to be neoplastic. This is another part of another cluster in which, once again, we lose the normal flat appearance of superficial epithelium. So this could mean simply that this cell can be neoplastic, or that these cells come from deeper layer of the lesion. And finally, we have another kind of cells that it would be nice to make a poll and to ask you what you think about this cell, because this is not an epithelial cell. Once again, we are in an inflammatory context, and this multinucleated cell is probably a cell of macrophagic origin. So it's another inflammatory cells, but of different origin. Okay, now it's time to decide, because the client is waiting in the other room, and we have to tell him something. So what do you think about this? Are you facing a tumor? Because we have a lot of feature, especially in the cytological examination of some part of the slides, and in the field of tumor, for sure, the squamous cell carcinoma is the most likely. Or we are simply an inflammation, because we have a lot of the eosinophils here, and the majority of the cell are inflammatory, and we have also a fibroblastic reactive pattern that can suggest that this inflammatory problem is a chronic inflammatory problem. For me, this was a case, I always believe that we can learn more from our mistakes than from the beautiful, perfect case that sometimes we see in some congress, in some group on internet. Because it's easy when someone tells us the diagnosis, but it's very difficult when we must decide, and our decision, our words, make the difference between the life and death. And I was really worried about this, because the owner of this cat was a friend of mine, and tell to a friend that this cat would die is not easy for me. And this is one of the reasons because I do not suggest euthanasia to this cat, I prefer to say, okay, some to compassionate this animal, say, okay, we can wait a little bit more. Probably the cat is not suffering, so we can try something to relieve the pain, to relieve the inflammation. What is the best treatment for inflammation in a cat with an oral problem? I think that the same drug is used all over the world, and I think that these drugs save a lot of life. So the story is as an end that is different from the case, and sometimes the real world is better than the theoretical world. So in this case, this cat, just to be compassionate, had a shot of depomedrol. And I think that everybody knows depomedrol is a steroid, deposit steroid. And I was really very surprised that this cat, in a couple of weeks, went back to normal, absolutely. No lesion was more seen in the mouth of this cat. The breathing noising disappeared, and the drooling disappeared in 10, 12 days. The cat started eating again, breathing beautifully, and this happened in November past year. So the story of this cat that got 3 shots of depomedrol and everything disappeared. This is a picture of a couple of days ago. And I was really surprised and also mortified, because I was quite sure that this presentation was consistent with a squamous cell carcinoma. And this is important for me, that everybody can know that this can happen, because I think that sometimes this cat can die because we strongly believe that this is a tumor, but it's not. So once again, cats teach us something, that they always had the last word. So don't trust cats, nor in happy cases or in sad cases like this. Yeah, so that's it. The case is finished. This is an happy ending now. But I want to show you this case, because sometimes it's very difficult to identify the limit between dysplastic changes in squamous cells, especially in the oral cavity, but also in other districts, and the true neoplastic change. And if you're not sure 100%, I suggest always to perform a wedge biopsy and to have an histological examination, because once that you make euthanasia, you cannot go back. And so it's important to make a little step more instead to choose the shorter way.
Okay. This is a great example of why pathologists say, follow up with histopath. We don't do it to be annoying.
Yeah, absolutely.
It's because of cases like this, because even though, sorry, that's my 2-year-old, even though we grabbed him, well, I have a runaway naked 2-year-old running through the house. And hopefully he won't hop up on the chair behind me. But yeah, this is a great example of that, because, I completely agree. Your cytology was strongly suggestive of squamous cell carcinoma because of those changes. And the eosinophil component is a little unusual, like we had talked about, because at least in my experience, they're often inflamed, but it's neutrophilic inflammation. And then you have that whole conundrum of, is this primary inflammation with dysplasia, or is this squamous cell carcinoma with the neutrophilic inflammation we often expect?
It's always the story. Dysphoria is the egg or is the chicken? No,
exactly. Exactly. Yeah. And I especially oral lesions, I had this, some of the things that you had said reminded me of a case I had of a cat with an oral lesion that they described as huge and necrotic. So you're obviously like, ooh, I don't know what huge means. Huge might be, everybody has a different idea of that, but but it certainly sounded concerning. And then I looked at the cytology, and there were just these horrible spindle cells everywhere. I mean, they looked horrible. And there was a very mild inflammatory component. And I just thought, I know better than to call this sarcoma because of what cat reactive fibroblasts can do. But I either straight up called it sarcoma, or I strongly suggested it. They did end up getting histopath on that. And thank God they did, because it came back as calcinosis circumscripta with marked secondary reactive fibroplasia.
Yeah.
And I was so thankful that they had done that, because the cat would have been euthanized. And, you know, those are the cases, just like you said, that make you like learn from those. And, you know, then you still have to find the balance between being helpful in cytology, you know, being a helpful diagnostic, but also being cautious enough to not, you know, cause more harm than good. So this is a wonderful example of that.
Yeah, it sometimes happen, especially when you don't know who is the people that getting the sample. Huh? We assume that people are skilled enough to understand exactly how many sample and how to take this sample. And this is one of the factors that mainly affect our interpretation, because we trust the sample that we have on the slides. And we must have a faith that these cells are truly representative of the lesion. And it's not always the story, absolutely. And sometimes we collect and we are looking at the cells that are absolutely distant to the true presentation, and this is a big problem. So, and this is the reason, because we must be always cautious in the reporting in cytology. We have to know our limits, unfortunately, even if we would, for example, to be more exhaustive, because we want to that the clinician is happy with our report.
Yeah.
This is okay.
Yeah, and yeah, that's a great point.
This is a question that what was the second diagnosis? So the second diagnosis was this cat has a eosinophilic granuloma complex that absolutely mimic a squamous cell carcinoma, especially because I ask a lot of colleagues about this case. No? I share this case because I was curious to know how many people have seen such presentation, and I didn't find anyone that say, okay, I've seen one like this. So in my experience, is my first one, because I cannot imagine that granuloma, eosinophilic granuloma complex can go so deep in the respiratory airways, and involve also the lymph node. And this was amazing. So the involving of the lymph node, in my opinion, is a typical behavior of a neoplastic process. Of course, we know that some lymphadenitis, we have neutrophils, etc. But in my experience, it's the first time that a granuloma complex stimulates such huge reaction and disruption of the tissue around the larynx.
There's another question on the Facebook feed. What factors are you looking for to determine if the neutrophils are inside the cytoplasm or on top of the cells? And specifically talking about the imperipolesis that you had mentioned.
Yeah, so, sorry, I'm reading a question and I lost your comment.
Oh, that's okay. On the Facebook feed, a question had been asked, what factors are you looking for to determine if the neutrophils are inside the cytoplasm or just on top of the cells when you were describing that imperipolesis?
Okay, yeah, it's a good question. In truth, we have no a good way to be sure about that. Generally, if you look at the immersion oil and you look at details, we can appreciate that the neutrophils are truly inside this cytoplasm. And basically, we know that this phenomenon occurs in the squamous epithelial cell. So it's not strange to find this. This has happened, for example, if you look at a vaginal smear. In a vaginal smear, you also can find, for example, this phenomenon of emperipolesis. And it's not rare to find. It's not a phagocytosis. It's a migration of neutrophils that goes through the cytoplasm to reach the final destination. I don't know if you, Kate, if you want to add something to to this description, this
Yeah,
phenomenon?
that's a good question, and that's come up before in the coffee house group. Also, it's a little bit hard to explain because, just like you said, it's not phagocytosis, and and I can see why it would be confusing to think, well, maybe they just landed on top of that cell. I think one of the things is potentially that those neutrophils are in the same plane as the rest of the squamous cell there. Presumably if it was sitting just on top of the cell, then it would be slightly out of focus, because it's in a different plane, even if it's a very small difference in plane. And so the fact that they're all in focus on the same plane.
Yeah, this is a great, yeah, absolutely.
And since they stay in the confines of the cell, they're not like overlapping a little bit, it's sort of, they just are huddling in that cytoplasm. That can help, but it can be hard sometimes to tell, just like you said. And it's just like you said too, like the expectation that squamous cells can do that, so
probably we are also influenced about that. But basically the problem is it's just a description, because nothing changed if we have an overimposition or is a true emperipoiesis in this case. Just I think that we can consider it like more a curiosity about the behavior of some cell, that a necessity to identify this feature because it has a special meaning.
Right. Mm-hmm. Okay. Looks like you've got several more questions coming through.
I'm trying to check. I'm trying to check the Facebook, but I'm okay. Yeah.
There aren't a bunch on the Facebook. There was one on the chat about can the bone become involved with eosinophilic granuloma complex?
May the bone be involved in eosinophilic granuloma complex? I haven't seen cases in which I have the bone involved, but this was my first case in which there is an involvement of larynx and the other soft tissue around the larynx. So I can say I didn't see, but I don't know.
I would think probably not. I mean, at least I've never. I'm trying to think of how that would happen. But then again, just like you said, there it is in the
like in the movie, never say never.
Right. Right. There's probably some publication out there that describes it that we don't know about.
Okay, and they say they make sense. Thank you for both the answer and the presentation. Okay. Okay, friends. I don't know how to describe how happy I am to have this evening, because for us now is quite night, 10 minutes past 10, and it's also nice to have this link between the USA and the old Europe across the ocean, and sharing the same passion. And I just want to finish with a reminder for you all cyto lovers. Just to remember that Kate has a fantastic course. I had the opportunity to see some lesson and the 5-minute lesson in the Mastering Hematology course. And in my opinion, okay, believe me, I'm honest. I didn't know Kate before, but when I saw such lesson, and especially the short lesson, I was amazed. Because the simplicity and the clarity of this presentation, and the funny way that Kate has to show this important knowledge about hematology, because the bases are the most important part, in my opinion. Experience need years, but experience without a good basis is not a good experience. That's it. I also want to mention, can you see the acronym here, MP, that means Malpighi Pathology Academy. It is an academy, is a non-profit academy that has a main goal is to share the knowledge of pathology. This is a human pathology academy, and also we have a veterinary division, quite recent. And we start also to organize some courses that was initially dedicated, focused to the basis for young vet, but now we expanded this because there is an increasing interest about this topic. And the fee also are very, very limited because it's a non-profit organization. So if you are just interested, you can give a look to the website that are increasing day by day because it's quite young. Okay, and I hope I don't know, Kate, what is the intention of Kate, but if it's possible, it could be nice to have another meeting in the future like this. And
for sure. Yeah, I'd love to. I'd love to. This is so much fun. Just for all the reasons you said. So yes, I would love to do this again. I think we have similar explanation styles, and it's a great collaboration. So thank you so much. Yeah.
We collect some suggestion, and especially from you, if you like something special, and we can try to arrange another nice evening like this.
Yeah.
So thanks to everybody from all over the world. And I just say hello. If you want to, Kate, if you want to close this session.
Sure. Yeah. Thank you again. I can't say thank you enough. This has been so much fun. We're about to go head out and get some early dinner. So it's still afternoon here, but yeah, we're this has just been great. So thank you guys. And thank you all for coming and watching. I know we've got people from all over, and you're all at different time zones. So really appreciate your time coming to talk, with us about cytology and these two really interesting cases. So thank you guys very much. And we'll see you next time, I suppose.
Okay, fine. Thank you very much. We will put on both pages the recordings of this meeting, so everybody can see when they can. And okay, see you next time from Italy.
Yes.
Bye.
In the US. Bye.